Infection prevention and control guidelines, ensuring safe eye care practices and protecting eye care professionals from healthcare-associated infections (HAIs). Objectives: to understand risks, hazards, and healthcare-associated infections in eye care. Learn core IPC guidelines tailored for eye care professionals. Explore strategies to protect practitioners and combat IPC challenges in resource-limited settings. Review practical case study and actionable materials. Purpose: to awaken the consciousness of eye care professionals to standard precautions for healthier eye health delivery. To highlight the importance of infection prevention and control in eye care settings. To protect professionals and ensure safe patient care. Participants: ophthalmologists, optometrists, nurses and technicians in eye care, healthcare administrators, public health professionals. Introduction: there are many reasons why health workers get sick. Our patients are our responsibility, so are we saying for ourselves? The essence of this presentation is to address one out of many of these reasons and promote safe practices for us and our patients. Infection prevention and control. Infection control is about eliminating, minimizing, or preventing the risk of acquiring infection during the provision of healthcare services. Risks and hazards. What is risk? Probability that an undesired adverse event or hazard will occur. Probability of acquiring an infection arising from activities within a healthcare facility. What is a hazard? A hazard is a situation, action, or event that may cause harm or damage. What is harm or hazard in infection prevention and control? Primary harm is pathogen transmission to new host or site, while hazard is situation, action, or events that lead to its occurrence, called risky activity. Example of risks or hazards in healthcare. We'll look at hazards and then the harm or the infection they cause. The hazards include insertion of strips or testing probes, staff members with boils, reuse of cottons, sharps, or equipment, performing invasive tests on a patient, the coughing patient, performing tests on an unsuspected infected patient without the appropriate personal protective equipment, PPEs, then surgical procedures. The harm or infection they may likely cause: conjunctivitis, wound infection, hepatitis, abrasion, infection, wound healing delays, endophthalmitis, respiratory infections, other infections such as TB, Lassa fever, anthrax. What are the infection risks? The infection risks are contaminated hands, direct contact with blood or body fluids from patients, contaminated clinical equipment, dirty environment, wastes, cottons, sharps, swabs, probes of tonometers and pachymeters, patients with communicable diseases, patients colonized or infected with resistant microorganisms. What increases risk? Invasiveness. This can come from devices or procedures that normally enter sterile areas and devices that have contact with mucous membranes. Shared items. They include thermometers, reuse of gloves, using same hands that touch patients without hand washing on other devices such as phones. Refilling containers also increases risk. They include buckets for mopping floors, ophthalmoscope holders, retinoscope holders, lotions, cotton containers, etc. Inadequate facilities, which can include crowding, long walk to sink, inadequate disposal of wastes, waste bins far from the practitioner, staff reusing supplies that are supposed to be sterile, other things that increases risk, duration of exposure. 30-minute surgery is less riskier than a 3-hour surgery. And living in a house with a person who has a communicable disease is riskier than a 2-minute encounter with same person. Healthcare associated infection. HAI is a potentially preventable adverse effect rather than an unpredictable complication. Any person walking in or entering a healthcare facility is at risk of transmitting infection or being infected. Effective IPC can significantly reduce the rate of HAIs. Understanding healthcare-associated infections. These are infections acquired in healthcare settings, including outpatient eye clinics. Common examples are endophthalmitis, conjunctivitis, herpes zoster, etc. The causes can come from poor hygiene to substandard sterilization, overcrowding, understaffing. The importance of understanding healthcare-associated infections is to prevent infections by ensuring patient and practitioner safety. In IPC, we are concerned with preventing infection prevention in healthcare delivery. Infections can be transmitted from patient to the surroundings where the patient is in, to the healthcare worker, and from the healthcare worker to our families, or even back to the patient. It can be a vicious circle. Core IPC guidelines for eye care professionals. 1. Hand hygiene. We need to understand proper hand washing techniques. 2. Equipment sterilization. Should understand disinfection and cleaning. Personal protective equipment such as masks, gloves, eyewear, gowns, etc. Environmental cleanliness, patient education, and good waste management. We look at each of them. Hand hygiene. Bacteria cannot walk, jump, or fly, but they sure can take a taxi. Our hands can harbor a multitude of microorganisms, and the number that can accumulate on the hands within the space of a few hours can be as high as 100,000 or more per hand. Bacteria can multiply with 2 divisions per hour. In 1 hour, it can be 1 cell. Under 2 hours, 4 cells. Under 5 hours, 16 cells. 16 cells to 4,906 cells. 10 hours, 1,048,576 cells. And in 17 hours of not washing your hands, you can get 17,179,869,184 bacterial cells without hand wash. Bacteria multiply enormously fast. Called from the Nigerian CDC, the term hand hygiene refers to action of cleaning hands either by using soap, under running water, or alcohol-based hand rub, referred to as hand sanitizing. There are 5 moments for hand hygiene according to WHO. 1. Before touching a patient. It applies to eye care professionals. 2. Before clean or aseptic procedure, like touching the patient's shirt, touching the patient's hands. 3. After body fluid exposure risk, like checking the conjunctiva, especially to a patient who is tearing. After touching a patient, especially during ophthalmoscopy, if there was a way you touched the patient, or during invasive procedures. 5. After touching patient surroundings, like the chair the patient was sitting or the place the patient stayed to do refraction and all that. These are the 5 moments for hand hygiene for the eye care professional, using the optometrist work as an example. Other moments of hand hygiene: on arrival at workplace, before and after nursing a patient, after visiting the toilet, before and after handling food, eating or feeding patients, before and after gloving, especially in the clinic. Routine hand wash involves washing hands with soap under clean running water, indicated whenever the hands are visibly soiled or dirty. Must always use soap. Liquid soap is advocated over bar soap, especially in public areas. Requires friction by rubbing hands together, ensuring that all hand surfaces are covered. This slide shows the frequently missed areas of the hand: underside of the hand, fingertips, thumbs, palms, interdigital space, the backs of the hands. So you take a good look at it. The areas that are important in hand hygiene, you can see that we usually miss the areas painted red, mostly frequently missed areas, our fingernails. We also have the orange places, frequently missed areas, and then we have the peach colored, less frequently missed areas. We look at proper hand washing and rubbing technique. How to wash your hand: you wet your hands, you take the liquid soap, you rub your palm, you rub the back of your palm for the right eye, for the left eye. You scrub your fingernails for the right hand, for the left eye. You wash your thumb, right thumb, left thumb. You wash the sides of your hands, right hand, left hand. Remember to scrub the back the same way. You rinse in the same direction and allow your hands to air dry, or you use a paper towel to clean your hands and throw the paper towel into the disposable bin. For hand rub, for alcohol hand rub, you take about 5 ml of the hand sanitizer at the center of your palm. Dip in your fingers first. Rub your palm, rub your thumb, scrub your fingernails again, your side, the back of your hands, and allow your hand to air dry. It is done within 30 seconds. Alcohol-based solution for hand rub: gel, sprays, and solutions. The hand rubs can come as them. They can kill 99% of microorganisms. It takes about 15 to 30 seconds to dry. It's quicker and easier to perform. It's effective, and an adequate amount of 5 ml. It will give an effective use. Please do not use the alcohol or hand rub, normally known as hand sanitizer, on your hands when your hands are visibly soiled. Please do hand hygiene using soap, liquid soap, and running water when your hands are visibly soiled. Skincare and hand hygiene: use hand lotions or creams to reduce skin dryness and cracking. Avoid injuries to your hands. Cover cuts and bruises. If you have allergies or adverse reactions, use alternative products such as latex gloves or soaps that are tailored to you. Do remove jewelries. It does limit effective rubbing of hands. Keep natural nails shut to avoid trapping dirt underneath. No artificial fingernails or extenders should be on you as a healthcare professionals because they harbor fungal infections. Old or cracked nail polish also traps pathogens. Do remember, hand hygiene must be performed at the point of care. The 5 moments that are essential: before patient contact, before clean and aseptic procedures, after body fluid exposure risk, after touching a patient, after touching the patient's surroundings. We look at equipment sterilization and environmental cleaning. Let's look at the definitions. Cleaning is the general removal of organic matter, dirt, food, blood, saliva, and other body secretions that contribute to proliferation of bacteria and viruses. While disinfection is a process of removing significant amount of pathogens that cause infection or disease and must be preceded by cleaning. Only items and surfaces that have come in contact with patient's skin and mucosa and are frequently touched require disinfection after cleaning, such as a slit lamp, the refractometer, the tonometer, the pachymeter, and the rest of them. Principles of cleaning. For the clinic, always move from the cleanest area to the dirtiest area. Clean from higher level areas to low areas, outer to inner. Clean examination or testing areas last with dedicated cleaning equipment. We do not use the cleaning equipment used for the toilets or the conveniences to clean testing areas or the patient's areas that are high levels. Damp dusting and wet mopping is recommended to minimize dust and not promote aerosols. Use a 3-bucket system for cleaning and disinfection. Water for cleaning should be clean water. Spraying of disinfectants is not recommended. This next slide, you'll be looking at steps to routine cleaning. On the diagram, we have assessments. You check what you have. You get your supplies ready. You do your hand hygiene. The patient's area is cleaned. There should be disposal of every bin that is there. And once it is done, you do your hand hygiene. This is for routine cleaning. But terminal cleaning requires assessment, supplies, hand hygiene, clean of patient areas, patient bathroom, floors, disposal, and hand hygiene again. Type of cleaning for different patient areas. Non-critical frequent touch surfaces such as equipment tables, face areas on refractometers, table chairs, and light switches must be cleaned, and toilets must be cleaned, then disinfected on a regular basis. The floors, the walls, and windows, chairs, and other furniture used by individuals who are clothed and other non-patient care areas require only cleaning. Bed curtains should be changed when soiled and changed with every terminal cleaning. This is for the ophthalmology hospitals. Equipment should be cleaned with every patient use: forehead rest, chin rest, the probes of tonometers, pachymeters, etc. The color coding of cleaning equipment for different areas of a health facility. WHO recommends yellow, color coding yellow. The corresponding area is infectious areas or isolated areas or waiting room areas. Red is for toilets, bathrooms, dirty utility room. Green, cleaning equipment should be for food service area, preparation area, medicines area. Blue should be general cleaning. White should be for the operating room. This next slide is showing color-coded cleaning equipment and cleaning agents. You can see the mops that are yellow, that are white, green, red, and blue, and there are different meanings as we have talked about. How to clean up body fluid spills. Sometimes patients come into our office and then they become sick. Some can throw up on the floor of the clinic, and other things can happen. We've had diabetic patients can just pee in the clinic. These are body fluids. They can happen in the eye clinic. In the ophthalmology space, it can also happen more frequently than in an optometric situation. So, how do we clean body fluids pills? Wear the appropriate PPE. By PPE, we mean personal protective equipment. It may be a gown or apron, rubber gloves, medical mask. Mix a fresh, not older than 24 hours, bleach solution. We call them 0.5% chlorine solution. It is a household bleach diluted in 110. This is what is needed for spill management. And 1:100 dilution is used for environmental cleaning. You lay absorbent material over the spill. Take up the material, discard safely when it comes to vomitus or blood. Apply the 1:10 disinfectant, that's the 0.5% chlorine solution. Leave it on for 15 minutes, then place an absorbent material over it and clean it up. Remove all PPEs, dispose appropriately, and perform hand hygiene. To clean a spill, you can also allow disinfectant to remain in contact with the spill area for a period of time, say 10 to 20 minutes. Gently pick up the material, place it in a biohazard disposal bag, clean spill area with disinfectant, that is a fresh bleach, place waste in proper containers, disinfect and dispose all PPEs, perform hand hygiene. This next slide is how to dilute the sodium hypochlorite, or called 0.5% chlorine solution. You take a portion of the household bleach to 10 portions, or to 6 portions of water. Doing that, you would have 0.5% of chlorine solution. Well, if you're going to have 0.05% of chlorine solution, it is 1 portion to 10 parts of water. So if you take half of a bleach, you're going to take half of that amount of water 6 times to make 0.5% chlorine solution. You can use it to disinfect areas of feces, blood, vomiters, other body fluids. And with that 0.5% chlorine solution, you can also make an extra 10. Add 10 other portions of water to a portion of the 0.5% chlorine solution for you to have 0.05% chlorine solution. And with this, you can disinfect all equipment without discoloration. You can disinfect to general cleaning, even washing of hands, linens that we even use to cover our equipment and all that. You can use this to disinfect them. Now we look at healthcare waste management. What is wrong with this picture? In this picture is a combination of so many medical wastes in one place. Without segregation, you can see sharp boxes, needles, even there's a little stream there. You can see gloves, you can see a lot of wastes around here, and they are all neglected in a particular place, who knows for how long. So a lot is wrong with this picture. You can also pick out some other things that I can't. The WHO has a recommended color coding system for waste segregation for clinics and hospitals in Nigeria, and that is black, yellow, red, and brown. Black is for non-risk wastes or general wastes. If your clinic does not generate waste at all or generates only papers, then you can use only the black waste material. Yellow is for infectious wastes, sharp boxes. Red is for highly infectious wastes, always generated in the suspect and confirmed ward, or patients with communicable diseases, or patients you're not even sure of. Imagine a patient with herpes zoster ophthalmicus with and RVS reactive with a mucopurulent discharge. So those cottons and everything used to clean up the patient will be in a highly infectious waste bin. Brown is for pharmaceutical wastes and some chemical wastes. Healthcare worker packaging for eye clinics. Do not load bags beyond their weight or volume capacity. Usually, it is advisable for wastes to be full 3/4 of the time so that it will be easy to lift and tie. Keep bags away from contact with sharp objects. The waste should be packaged securely enough to ensure containment and to prevent penetration by rodents. Hand hygiene must be performed after every waste disposal. No waste should be stored for more than 2 days before being treated and disposed of. Wastes should be well covered. The waste storage. The designated central waste storage facility shall be totally enclosed and secured from unauthorized access and inaccessible to animals, insects, and birds. The designated central waste storage facility should be easy to clean and disinfect and must have an impermeable hand-standing base, good water supply, drainage, and ventilation. This applies to ophthalmology hospitals. Waste handling. All healthcare wastes or disposal of medical equipment shall be disposed of at the point of use by the person who used the item, cradle to grave. Example, after using the Schema strip, the person who inserted the strip should be the one to put the strip in the waste bin. The person who used the cotton wool to clean up a patient should be the one to put it inside the waste disposal bin. That is the meaning of cradle to grave. But in case used and contaminated material is found, when not disposed of or handed over by another person for disposal, the one who finds it or was given the responsibility should dispose of it. And please don't forget hand hygiene. We now look at personal protective equipment. And this will take us to the point of care risk assessment. This is to help us in the use of the PPE. For every PPE used, there should be a risk assessment done at every patient encounter, because the responsibility of every healthcare worker is to assess risk. A point of care risk assessment should be done for every patient encounter. Every time processes involve patient body fluids or tissues, every situation in which there may be transmission of organisms. Protecting the eye care professional. Every eye care professional is exposed to risk, and this may include infectious materials such as body fluids, sharp tool injuries. Preventive strategies may include vaccination and proper use of our PPEs. The mental health of the eye care professional, addressing burnout and stress, needs to be evaluated periodically. There should be proper staffing so that overwork will not make a staff forget to do their hand hygiene or execute infection prevention protocols. Point of care risk assessment is useful to enable healthcare workers to identify the additional steps needed to be taken to protect themselves, the patients they care for, and others in the environment, such as their families, their caregivers, their visitors, and the healthcare workers. Personal protective equipment. We wear PPE to avoid direct contact with blood, other body fluids, respiratory secretions or excretions, mucous membrane, and non-intact skin. We put on PPE according to the anticipated contact with the above. Wearing PPE is always procedure-based. We put PPE on before procedure and remove directly thereafter and perform hand hygiene. Remember that instruments, equipment, supplies, and even hard surfaces can be contaminated. The contamination is not always visible. PPE has some rules. It can be a transmitter of microbes when contaminated. The use of PPE to allay personal prejudice or fear without indication for a procedure can sometimes increase the risk of infection. PPE use is not a substitute for poor infection control practice or healthcare and nursing procedure. All PPE have limited lifespan and must be discarded after use as indicated, usually after each patient or patient cohort use. We'll be looking at PPEs according to the level of care and risk for eye care professionals. This is tailored and narrowed down to the optometric practice. Triage. Hand hygiene, yes. Medical mask, yes. Gloves, not necessarily. Assessment of discharges, yes. Hand hygiene, medical mask, yes. Gloves, yes. When performing invasive procedures, would you do hand hygiene? Yes. Medical mask, yes. Gloves, yes. In some cases, you may need the face shield, the N95. If you have a patient who is coughing and have to go through invasive procedures. Hand hygiene for performing non-invasive tests, yes. Before and after. Medical masks, not necessary, unless during triage you have patients who are coughing. Even when you are not about to perform any non-invasive tests such as refraction or taking visual acuity for ophthalmic nurses and assistants. So medical masks may or may not be indicated. The same applies to gloves. Collection of specimen or administering injections. Would you do hand hygiene? Yes. Medical masks also indicated. The gloves also indicated. This is a slide that needs to be discussed. Combating IPC challenges in resource-limited settings. The challenges include lack of sterilization procedures, limited personal protective equipment, overcrowding, poor waste management, and nonchalance of healthcare workers. The solution: low-cost sterilization methods, task sharing, partnerships for supplies, trainings for healthcare workers. We'll be looking at some case studies. We'll look at the outbreak of conjunctivitis in an urban eye clinic. And then we also look at a small assignment that we have to discuss. So we look at this case study. The outbreak of conjunctivitis in an eye clinic due to poor infection prevention practices. The background. An eye clinic in an urban area experienced an outbreak of viral conjunctivitis affecting 21 patients and 3 staff members over 2 weeks. The clinic primarily handled routine consultations and minor surgical procedures with an average patient volume of 60 per day. Let's look at the timeline of the events as they unfolded. Day 1. A patient presented with symptoms of acute viral conjunctivitis, redness, tearing, and itching, but was not identified as infectious during triage. The patient underwent a slit lamp examination. Day 3. 5 patients who had been seen on the same day as the initial patient reported similar conjunctivitis symptoms. No immediate investigation was initiated. Does it ring a bell? Day 5. A staff member who had handled the diagnostic instruments without gloves or disinfection developed conjunctivitis. Day 7 to 14, the outbreak escalated to 21 patients and 3 staff members, causing panic among patients and disruptions to clinic operations. Investigative findings. An internal review identified several breaches in infection prevention and control practices, including 1. Inadequate instrument cleaning. Diagnostic tools like the slit lamp and tonometer were not infected between patients. The staff also relied on end of the day cleaning instead of cleaning after each patient interaction. Poor hand hygiene compliance was the second thing observed. The staff were observed skipping hand washing between patients. Alcohol-based hand drops were not readily available in examination rooms. 3. Lack of PPE use. Staff conducted examinations without gloves or protective goggles. Masks were not used consistently. 4. Improper patient screening. No protocol was in place to identify potentially infectious patients during triage. Consequences of these actions. A. The health impact. 21 patients developed conjunctivitis. During follow-up care, an additional treatment was to be done. 3 staff members were infected also, resulting in absenteeism and reduced workforce. B. Reputational damage. Patient trust in the clinic declined, with complaints filed to the local health authorities. C. Financial losses. Costs incurred for outbreak containment, such as staff overtime, purchasing additional disinfectants, and compensating patients, brought loss. The corrective actions taken. 1. Implementations of IPC guidelines. These include cleaning and disinfection protocols. They had to be revised to include thorough disinfection of all instruments, example slit lamps, tonometers, etc., between each patient. Alcohol wipes were placed at each station for quick and frequent disinfection. 2. Hand hygiene training. Staff members were retrained on proper staff hygiene techniques. Hand washing stations and alcohol-based hand drops were installed at multiple points in the clinic. Mandatory PPE usage. Staff were required to wear gloves, masks, and protective goggles during all patient interactions. Remember your point of care assessment, risk assessment, POCRA, point of care risk assessment. You need to do that before you choose the type of PPE to wear from the time you're triaging patients to the time patients are seen. 4. Triad screening protocols. Patients with infectious symptoms, red eyes discharges, were identified at check-in and directed to a separate waiting area. This is called triaging. When you are able to identify someone who comes into the reception, mixes with others, with a red eye, with tearing, with discharges, with cough, you should be able to isolate the patient, keep the patient in a waiting area. Where you do not do that, where you're not able to do that, the patient should be able to be seen first before any other person. Hand hygiene is important to the clinical staff to do, and proper PPEs when risk is assessed should also come into place when seeing such patients. 5. Staff vaccination and awareness. Vaccination campaigns for influenza and other infectious diseases should be conducted. We are conducted for this case. The lessons learned. IPC practices saves lives. Strict adherence to IPC protocols can prevent the spread of infections in high-risk environments like eye clinics. Regular audits are essential. Periodic reviews and audit of clinic practices ensure compliance with guidelines. Preparedness matters. Clinics must establish outbreak response plans, including rapid containment measures to minimize harm and disruption. Now the classwork. Mr. A has low-grade fever, running nose, headache, cough for some days, purulent discharge in the eye, red eye, tearing, and turns up at the eye center outpatient. A. What will you do in order of importance and why? Is the patient able and willing to perform cough etiquette? Does he require a mask? Is the patient able and willing to perform hand hygiene? Is the patient in a single room or mixed up at the reception with other patients? What procedures do you want to carry out? How will you prevent transmission to yourself and others? The references for this presentation were gotten by WHO IPC guidelines, CDC recommendations for ophthalmology, and Nigeria Center for Disease Control. For your questions and feedback, please share your questions or feedback. Contact us at Odorbn Education Department at gmail.com or chiginaka@gmail.com. The key takeaways: implement IPC measures effectively in your eye clinic. Call to action: apply learned protocols from this presentation. Contact us at Odorbn Education Department at gmail.com or chiginaka@gmail.com. Thank you.